Welcome. I'm Josh Horowitz, the Executive Director of the Educational Fund to Stop Gun Violence. Thank you for joining us today. At the Ed Fund, we use a public health and equity lens to identify and implement evidence-based violence policy solution and programs to reduce gun violence in all its forms. We seek to make gun violence rare and abnormal. I'm also the Executive Director of the Consortium for Risk-Based Firearm Policy. The consortium is comprised of experts committed to advancing evidence-based gun violence prevention policies. The group includes the nation's leading researchers and academics with expertise at the intersection of gun violence prevention, public health, law, behavioral health, medicine, criminology, and related fields. The incredible and talented staff of the Educational Fund supports the work of the consortium, and the effort is funded by a generous grant from the Joyce Foundation. And on a personal note, it is an honor to work with this incredible group. Best known for its development of the Extreme Risk Protection Order Policy, or IRRPO, the consortium has also published reports on best practices for firearm removal in cases of domestic violence and guidelines for practice and training in lethal means safety counseling for firearm suicide prevention. The consortium original IRRPO recommended IRRPO in 2013. It resulted from our very first meeting where we tackled the relationship of firearms violence and mental illness. In a string of mass shootings, there were calls to base new firearms prohibitions on mental health status or diagnosis. The consortium rejected this approach because the evidence showed that most people with mental illness were not a threat to harm self or others. Instead, we adopted an approach that developed a new time-limited civil restraining order that would temporarily remove a firearm from someone exhibiting behavioral risk factors like threats or acts of violence that put them at risk of harm to self or others. We further recommended that this approach be judicial, include robust due process protections, follow the well-established process of domestic violence restraining orders. The consortium's original IRRPO recommendation led to IRRPO being passed in 17 states and the District of Columbia. Studies of IRRPO are now providing suggestive evidence of their effectiveness in preventing gun violence. Multiple studies indicate that they can be a valuable suicide prevention mechanism, and new research suggests that they may help prevent mass violence as well, including school shootings. As states enact and implement IRRPO laws, there's been a predictable variation in how the laws are written and implemented, reflecting states' diverse needs, priorities, and barriers to implementation. These differences, however, have raised questions about best practices, and stakeholders have turned to the consortium for specific guidance. Today, we offer additional guidance in a new report, Extreme Risk Protection Orders, New Recommendations for Policy and Implementation. While we are all very excited about the report and the recommendations, we stress that this is an iterative process, and we expect to continue to evaluate IRRPO and issue new recommendations over time as data becomes available, especially about the law, how the law is being implemented to make sure that it's implemented effectively and equitably. Now, I'm about to introduce our incredible panel today. I also want to make a point that you can put questions in the Q&A. And of course, we're all dealing with new technology today. So we've planned for some contingencies, but you just don't know here. So we'll do our best in this new world. So alphabetically, our panelist starts with Paul Applebaum. Is the Elizabeth K. Dollard Professor of Psychiatry, Medicine, and Law in the Department of Psychiatry at Columbia University. Dr. Applebaum is a past president of the American Psychiatric Association and has been elected to the National Academies of Medicine. He's the author of many articles and books on law and ethics in clinical practice and research, and is a founding member and a steering committee member of the Consortium for Risk-Based Firearm Policy. Next, Christopher Carita joined the Fort Lauderdale Police Department in 2009, where he currently serves as a detective with the Special Investigations Threat Response Unit and is a member of the Crisis Negotiation Team. Christopher investigates mass casualty threats, political violence, and extremist groups. Additionally, his unit is responsible for investigating all incidents that may require the use of an extreme risk protection order. Christopher is currently a Bloomberg Fellow at the Johns Hopkins Bloomberg School of Public Health with a focus on violence. He is implementing interdisciplinary programs that are proven to save lives and shifting perspectives on law enforcement's role in public health. He has contributed his experience and perspective to our organization's review of IRRPO implementation and continues to consult on current IRRPO research. Vika Chaplin is the Director of Research Translation at the Educational Fund to Stop Gun Violence. In this role, Vika translates research findings into effective gun violence prevention policies, practices, and further research. Vika also serves as the Managing Director of the Consortium for Risk-Based Firearm Policy. She oversees the development of our reports, our recommendations, administers the consortium's convenings and communications, and fosters collaboration among its members and contributors. I want to give Vika a special shout out for leading this incredible effort. Thank you, Vika. Lauren Footman is the Director of Outreach and Equity at the Educational Fund to Stop Gun Violence. Lauren works to empower and amplify impacted communities, but providing them with tools and resources to cultivate safe and sustainable communities. Lauren has worked with local and national organizations on civil rights and gun violence prevention, working at the intersection of policy, community organizing, and philanthropy. She has implemented diversity and inclusion programs and focused on coalition building. Shannon Frateroli is an associate professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health, where she serves as a core faculty with the Center for Gun Violence Policy and Research. Her research focuses on policy strategies designed to prevent injury and violence, particularly firearm-related violence, including intimate partner violence involving guns. Dr. Frateroli has been involved in efforts to advance the implementation and scholarship around IRRPO laws. She is a founding member and a steering committee member of the Consortium for Risk-Based Firearm Policy. So let's dive into the new report. And I'm going to ask the first question to Vika. Vika, what's in the report and what are the most important findings?
Thanks, Josh. I'm so happy to be here today and get to talk about this report. We are issuing 6 new state policy recommendations and 2 sets of federal policy recommendations. This is a state level policy that can be supported at the federal level, so we thought it was important to do both. So the first area of recommendation is about the duration of orders. As Josh mentioned, 19 states in the District of Columbia have extreme risk laws. The details of those laws do change state to state, and some questions were coming into the consortium about what it should look like, how long should these orders last. And so the new recommendation is that the temporary, the ex parte orders last 2 to 3 weeks, which then can be followed by a final order lasting 1 year. Now, part of what's important here is opportunities for respondents to file for an early termination. They can do that, according to these recommendations, 1 time per year, which would happen, I say per year, because there's an opportunity for renewal in the last 90 days of the year. The consortium is recommending that that renewal petition be based on recent evidence if a threat continues. Renewal petitions should also be lasting for 1 year. There are 2 exceptions that the consortium is recommending. The first is if there's an impairment that's associated with a condition that's either stable or declining. So that means that the risk level will stay the same or increase over time, that then a longer renewal order could be issued. And the other exception is if the respondent is requesting a longer order. There have been cases where people want the IRRPO to remain in effect for a longer period of time for one's own safety. And if the respondent is requesting that, then that should be an option. So the second area of recommendation is third-party clauses. This is so that if guns are removed that do not belong to a respondent, that the legal owner can petition a court to have those firearms returned. Now it's important to have that return happen with a plan so that the respondent does not have access to the firearm. This has come up as a question in cases involving minors at risk of violence. In the past, the consortium did not address whether an IRRPO should be an option or applicable to minors. At this time, we are recommending that IRRPOs be applicable, to minors regardless of legal firearm ownership, but that of course does allow that a third-party clause, if for example, a parent owns a firearm, that the parent could petition for the return of the firearms. I think we'll get some options, some opportunities to discuss minors as respondents potentially later in the discussion. But we thought it should be an option that's available if a minor has access to a firearm or could become eligible to purchase a firearm in the duration of the order. There are special protections that should be in place for cases involving minors. In particular, we wanted to make sure that court records be confidential and then sealed following the termination of the order. The fourth area of recommendation is regarding eligible petitioners. The original recommendation from the consortium for IRRPO recommended that law enforcement, families, and household members be able to petition for an extreme risk protection order. And now we are expanding that to include licensed healthcare providers. We want to make sure, I know we'll have a discussion about that as well from Dr. Applebaum, but we wanted to acknowledge that healthcare providers are often at the front lines of a crisis that could be helped with an IRRPO. In order to make that more accessible to healthcare providers, so that this could be a reasonable option for healthcare providers to petition for an IRRPO, we recommend special training and clinical coordinators who can help ease that process. We also recommend granting liability protections for healthcare providers, both for petitioning for an IRRPO, as well as when a healthcare provider would choose not to petition for an IRRPO. The fifth area is submission of records to NICS, that's the National Instant Criminal Background Check System, or depending on the state background check databases. This is important because when someone goes to buy a firearm, if they're the respondent to an IRRPO, that needs to be entered into those databases so that at the point of purchase, they're denied. Those should include expiration dates and also any renewal information that's available for the IRRPO. And finally, at the state level, data should be entered into a state database. That should be a centralized state database, and the state should then facilitate access to these data for research and policy purposes. One of the things that's underlying everything that the consortium does is research. We want to make sure that we are making recommendations that are grounded in evidence. And in order to continue that and to learn as these policies continue to grow and be implemented in new ways, is that we can continue to study them and improve the recommendations as we go. And then at the state level, or sorry, at the federal level, the federal government can support states can support IRRPOs in two really important ways. First is supporting state policy implementation. So we've recommended federal grant funding to support state implementation of IRRPO policies in 6 different areas. That's building infrastructure, training, education, enhancing social services, supporting research, and improving state reporting to national background check systems, the national background check system. And then finally, we want to also recommend funding for NICS, the National Instant Criminal Background Check System, so that we can ensure that IRRPOs effectively serve as firearm purchase prohibitors.
All right, Vika. So thank you so much for that. There's a number of new recommendations in there. I think one of the sort of ones that should jump off the page is the healthcare providers. That's something that a few states have, not every state has. That's something that we spent a lot of time with over the last 12 months or so. Paul Applebaum, do you want to talk as a licensed healthcare provider? Do you want to talk about what that means and how you would approach that?
Sure. So healthcare professionals of all sorts often come into contact with people who present with a strong likelihood of harming themselves, usually themselves, and less commonly other people. This is true not just for mental health professionals, although it may be especially true for in those cases, but for emergency physicians, primary care practitioners, and even specialists may see such people. Today, when those people who they believe have that strong likelihood of harm have guns, healthcare professionals are caught. They may feel responsible to prevent harm from occurring, but also helpless to do anything about it. It's important to note that involuntary hospitalization, involuntarily hospitalizing somebody for psychiatric reasons, which every state permits, is not necessarily the answer here, because it's not always an option. By no means is every dangerous person with a gun mentally ill. In fact, studies make very clear that with regard to harm to other people, most are not. In other words, the overwhelming majority of assaults and murders committed with guns are not committed by people with a diagnosable mental illness. Moreover, some state laws are sufficiently restrictive that even dangerous persons with mental illness may not be allowed to be committed. For example, some require an actual threat of harm and an act in furtherance of that threat. Pennsylvania is an example here, which clearly may not be met in many cases. So some other tool is needed, and an IRRPO provides healthcare professionals with that tool that they can use to reduce the risk of harm in such circumstances. Now, I think it's important to note that healthcare professionals have two very legitimate concerns about IRRPO laws. First, they're concerned that they may be held liable when a law exists if they fail to invoke it and harm results. And second, they may be concerned that if they do invoke it, an angry person may sue them for doing so without sufficient justification. So they're really caught between a Scylla and Charybdis here. That's a legitimate concern. And it's addressed in the consortium's recommendations by urging that states extend the right to petition to licensed healthcare professionals, but that they include a good faith immunity clause that would bar the imposition of liability for decisions that are made in good faith, either to file or not to file an IRRPO petition. And let me say that, because I know this is one of the questions that's already been asked, in terms of the scope of licensed healthcare professionals, the recommendations do not go specifically further than that. The discretion here would be left up to the legislature as to how broad that definition should be, but by no means should it be limited to mental health professionals, because they're only going to see a minority of cases, particularly with regard to danger to others. The second concern that health professionals legitimately have is the time involved in filing an IRRPO, and especially in testifying at a subsequent hearing, which may require taking time off and traveling to court. Obviously, a reasonable concern given the pressures on healthcare professionals, even when we're not in the middle of a pandemic. But it can be addressed by empowering in the enabling statute healthcare facilities and public health departments for practitioners who don't work in facilities to designate somebody, a clinical coordinator, let's call them, who can advise practitioners on the process and can then take over and manage the petitions, file them, and provide the testimony. I would note that similar positions exist in many healthcare facilities, when it comes to filing petitions for alleged child abuse and take the burden off frontline professionals, thereby facilitating their willingness to make these reports. So taken as a whole, these are an important component of the recommendations in the current report that should serve as a basis for a reasonable and functional, which is of supreme importance, system that allows healthcare practitioners to file for IRRPOs when indicated.
Well, thank you so much. And we're going to go back to healthcare in a minute, but I want to step back for a second and look at all the recommendations and ask Lauren, from your perspective, what makes IRRPO a valuable resource?
Thanks, Josh. So what makes IRRPO a valuable resource is, number one, that it is a preventative tool for those that may be at risk of harming themselves or others, and then also that in its intent, it is a civil tool. And so particularly in a lot of the communities that I interface with, we have a lot of conversations about the tool and really recognizing some of the context that interacts that we consider with communities of color and their experience with law enforcement. But one of the great things about this tool is not only does it serve as a preventative tool, but it's also a civil tool that can allow people in communities to get access to help for themselves in their community.
Let me just ask a follow-up for that. What do advocates who are working to implement this need to consider to make sure there's equitable implementation?
Number one, I think a big part of this is building authentic relationships with community members along the way. As we know in our work at the Ed Fund, a big part of how we have been able to connect with people around IRRPO and other policies is that we've had ongoing authentic relationships with them. So I think number one, taking into account the role of community in all policy development and not just getting their input or insight at the implementation phase, but also another part of that is thinking about how their voices are heard when maybe they don't agree or when they do have opportunity for growth. So I think it's number one, engaging them authentically, being willing and receptive to potential feedback if there is any. And I think one thing that we really want to make sure to highlight is that we definitely understand why communities who have been disproportionately impacted by different interactions with law enforcement would have concerns, but making sure that we are not projecting maybe potential opinions on communities, but really taking the time. A big part of this process is listening to those communities to see what their concerns may be. And then also thinking about how we can start to mitigate potential and disproportionate inequities that may exist once the law may be implemented. And a big part of that, Josh, is really thinking about how we collect data and recognizing that data is such an important part because, again, we understand the historical context, but we want to actually see what the data is telling us about how these laws are subsequently being implemented. But as we collect that data, making sure that community members who we've been building relationships with are able to be a part of those conversations and help us think about new additions to potential guardrails.
So that sounds like good advice for basically for all of our advocacy efforts. It's something that we should take into account for all the things we do, I think.
Yes, absolutely.
All right, great. Well, those are good lessons. Thank you so much. Shannon, you do collect data, so I want to hear a little about that. But first, I want to ask you a question about, you've worked, Maryland, I think, has been one of the leading implementers of their IRRPO legislation. They have a lot of orders, seems to be developing with a lot of success. But Maryland has right now one of the few states that actually has healthcare providers as a petitioner. What's any lessons we can learn from that, and anything that we should know from the implementation efforts so far?
Yeah, thanks, Josh. So Maryland, so you're right. So Maryland was the first state to include healthcare professionals as petitioners in their IRRPO law. And so we've had this in place for almost, well, a little over 2 years. October 1 was 2 years for us. So we have learned some lessons. We've learned some lessons that I can share anecdotally from many conversations with clinicians in the state. We've also done some research, so I can, so my response is also informed by that.
Yeah.
So we, a group of us surveyed clinical specialist physicians in particular from psychiatry, emergency medicine, and pediatrics at our hospital at Johns Hopkins Hospital. And we saw, like Paul said, that it's important for this authority to rest not just with mental health professionals. As a matter of fact, emergency room physicians overwhelmingly supported the use of IRRPO, and in some cases were describing that they saw patients, upwards of several times a month that they could imagine using IRRPO with. So this is an important opportunity that we see in the clinical environment in emergency settings, but also in the course of other types of patient care. So assuring that a wide range of clinical professionals have access to this tool is really important. But I also want to say that some of the lessons that we've heard are exactly what Paul has touched upon, exactly what the consortium's recommendations really highlight with regard to implementation of this clinician recommendation, which is that we need to make sure that healthcare providers are aware of this law. In our survey, the overwhelming majority of physicians that we asked didn't know what IRRPO was. After we provided them with a brief explanation, then they were able to answer questions about how they might use the frequency of their use. But even in a state, in a place where there's a lot of implementation of IRRPO, our clinical providers were sort of left out of that loop. So education's important. And making sure that we understand how IRRPO can work in the clinical environment is important. So what we see in Maryland is that about half of our petitions are made by law enforcement, about half are made by family members, partners of the respondents. And I know that two halves make a whole, but somewhere around 1% of our petitions are filed by clinicians. So to date, clinicians really haven't been engaged. But when I talk with clinicians, when we survey clinicians, they are so excited about this opportunity, about the opportunity, as Paul said, to really get unstuck when they have a patient who's clearly behaving dangerously and at risk of violence, but they haven't done anything wrong yet, and they can access guns or they have access to guns. They see how IRRPO can provide a ready tool for addressing that situation. So one of the key things that we hear from clinicians is the time barrier, as Paul mentioned, and putting clinical coordinators into place can really go a long way, we believe, in terms of making IRRPO not only a tool that's available for clinicians, but one that's viable that they can use. And I guess I'll just end by saying I want to build on something that Lauren said, which another way to sort of improve our implementation efforts around the clinical community is to make sure that we're inviting them into the conversation early and often, right? So we can hear about some of these barriers to implementation. We can hear their concerns and make sure that we're addressing them as we move forward.
Thanks, Shannon. And I think that goes to the iterative process, right? This is a process we're involved with. We're going to learn a lot more over the next years, maybe even decade, and we need to keep adjusting and learning and making this as good and as productive tool as possible. So thank you for that. Let me turn to Christopher Carita. Chris, you're in many ways on the front lines of this. I know you're very involved, as you actually participate in a unit in the Fort Lauderdale Police Department that gets to decide when IRRPOs get issued, or at least makes the decision to bring them. But I want to first want to ask you a question that came out in the recommendation in this report, which is that minors be potential to be a respondent in an IRRPO proceeding. Is that a way to engage with minors, and what have you seen from your experience with minors and IRRPO?
Thanks, Josh. What we've seen with minors when we have a case where there's been a threat, so often children, especially high school age adolescents, act out when they're feeling frustrated, and they say, just like we all did when we were kids, you say and do things that you don't really mean in that emotional moment. But in today's times, those incidents need to be looked at. In Fort Lauderdale, we have the advantage of having a unit that specifically investigates those incidents. And what we've seen is that when we're investigating those incidents and we have IRRPO as a tool, we have a way to prevent these incidents from becoming a criminal issue. And we have an intervention at our disposal that can remove the threat of firearms from the situation, whether that's removing firearms owned by the parent. We've had cases where it's a grandparent who regularly watches the child that has a firearm in the home. It gives us an opportunity to intervene without creating a criminal history for a child who may otherwise not have any issues as far as violence goes. This may be an isolated incident. This may be a cry for help. And it gives us an opportunity to work with the family to find the resources that that child and possibly even the entire family needs to be connected to, without creating a criminal charge and without getting the courts involved on that side of the house. So it's been a tremendous tool. We're lucky so far in that families that we have dealt with who may own firearms and who have had a child who is a potential respondent for an RPO, they've been very cooperative. And again, that goes to law enforcement doing a good job of building relationships with the people that we're investigating, that we're trying to protect ultimately. And so far, when we've had situations where there is a child who either needs to be a respondent for a risk protection order or just is in a situation where they're in crisis, the parents have been cooperative with surrendering the firearms or securing them at another family member's home. So we've had great success in having it having more than any other part of the population, adolescents, youth, preventing them from having to enter the criminal justice system for behavior that honestly is just part of growing up and making mistakes. Having a tool that can keep them safe, keep their family safe, the community safe, and prevent them from entering the criminal justice system unnecessarily has been tremendous.
Thanks, Chris. Is there any, I think you maybe touched on this, but is there any sort of special considerations you need when the child's involved? Anything that you do differently as far as, enforcement, removal, things like that?
We, especially when a child is involved, with any case where we're conducting we're conducting an investigation involving a risk protection order, we do our best to try to touch on as many of the people involved with the respondent in their day-to-day life as we can. We want to get a whole picture. Was this whether it was a threat made aloud or an action? We want to get a whole picture of the context of that, and we try to use IRRPO as judiciously as we can. If we can exhaust other interventions, if we can connect them to services, and we truly believe that they're not a threat, that this was an isolated incident, and we can connect them to services to start getting them the help they need, then we do utilize those services first. And ultimately, if an IRRPO is needed, but by the time we get to that point, everybody's already on board. We've already built the relationships to kind of make it happen and make it successful.
So one of the things I've been kind of, as we talk back and forth and you've impressed upon me is more that this is actually, in many ways, it can be oftentimes very collaborative and working with other stakeholders. And this goes beyond minors, right? So I think there's often an image of, this just being sort of a cold removal, but that's not what I'm really hearing from you and other stakeholders who are involved in this. So maybe you could talk a little bit about that, what that looks like for anybody.
Sure. So what I've really found to be the most valuable aspect of the IRRPO legislation here in Florida is that it doesn't hamstring the law enforcement agency using it as far as their own implementation. So it's become a pretty versatile tool. We've had incidents of extreme domestic violence where the victim is petrified and does not want to engage with the courts, does not want to take the steps to get their own protection orders. RPOs, as they are in Florida, IRRPO has been a tremendous tool for us, and what's valuable about that is then law enforcement gets to own that. So we track that. We track that risk protection order where we don't really track domestic protection orders in that same way. So when we're responsible for it as a law enforcement agency, we take ownership. So with my own unit, all the risk protection orders that I've investigated, that I've sworn out to, I own those. Those are my cases. So when it comes on a monthly basis, I'm checking on the respondents. I'm maintaining communication with the family members, with schools in some cases, with all the stakeholders. So when a year comes up, I have a full picture of, has this person made progress? Are they deteriorating further? And we can make an educated decision as to whether or not we need to extend that. But I think, again, going back to, we've used risk protection orders in situations where somebody is expressing suicidal ideology, interpersonal violence, domestic violence, all the way up to mass threats. And it's again, it's a tremendous tool that is outside of the cumbersome work that goes into the criminal justice case, a criminal case, and when you explain it, when you have officers that are explaining it well to the people involved, I would say 9 times out of 10, the respondent, the family members, everybody understands, and we get cooperation because they understand this is not criminal, this is temporary, this is a safety measure, this is about their health, this is about their life. It's not about punishment, and it's about them getting better and moving past whatever crisis they're going through.
Thanks, Chris. I've got lots more questions for you, but we do have some audience questions that I want to jump into. The first question was about background checks. I think the bottom line is, does this work better with a background check system in place? So maybe I'll throw that first to Shannon and then to Chris.
Sure. Well, so part of what IRRPOs do is to say that the respondent to the order isn't allowed to purchase new guns, and they're not allowed to possess guns. So in order to, make sure that that purchase function doesn't happen, we need to make sure that all avenues of purchase are covered, right? So without sort of that comprehensive background check system that's in place and being implemented, that also requires implementation efforts. What we have is a system that is really only effective at the level of purchases from federally licensed firearm dealers. So with background check systems, a comprehensive background check system that also includes sales between private individuals, that would certainly be more effective.
Chris, did you want to, do you have anything you wanted to add to that?
Sure. So again, Florida does not have any background checks attached to person-to-person sales. We're in that little gap. And I think law enforcement agencies have to be creative to fill that gap. And again, our agency kind of saw the writing on the wall with that and understood that once you have that RPO, ultimately, especially in the eyes of the public, you're going to be responsible for that person and for following up. So we found that the RPO law can be extremely effective if you find other means to follow up with the individual. So we make sure, again, everybody is a stakeholder, family members, co-workers. We make contact with as many people involved as possible, and everybody keeps an eye out on the respondent. Everyone, I'll get a phone call. Hey, Jimmy's not doing so well this week. He's been really angry. Everything's taken a turn for the worse. I think maybe you want to talk to him. And it's been a great tool to bring everybody on board, because everybody understands, again, they're not potentially sending their friend, their family member to jail. They're getting them help. And people are understanding that when it's explained to them, and it's been a tremendous tool, even in the face of a gap like background checks for person-to-person sales. I think there are other ways to fill that gap. Obviously, I would love to see a universal background check law, and that would obviously strengthen the IRRPO law that's already here. But we're working with what we have, and we're happy to have the tool.
Okay, thank you so much. There was one question very specific about, did we consider teachers as petitioners in this new report? And I want to throw that to Vika for this.
Yes, absolutely. We did discuss the role of teachers and educational administrators in IRRPO petitions. I think there are 3 states, don't quote me on that, but I think it's 3 states now that do include education personnel in their eligible petitioners. And ultimately, after hearing from educators and a number of representatives from the education community, we decided not to make a recommendation on it. There's not enough information for the consortium to weigh in at this time with a recommendation.
So it does take a lot of thought for us to do this, right? So it's not something we're just going to jump in without all the evidence and without our deliberative process. I think that's something that's the hallmark of our work. So it's not something I mean, potentially we could look at it in the future, but we just don't have, we haven't looked at it currently, right? We're not rejecting or accepting, we just haven't looked at it yet. Is that sort of our status, right?
Exactly. We're commenting on and issuing the recommendations on the things that that are in the report and we're ready to recommend on, and all other aspects, it's not a yes or a no. It's that we're choosing not to comment at this time because we don't have enough evidence. We don't have the right kind of backing that we feel is necessary in order to issue a recommendation from the consortium.
Okay, thank you so much. I'm going to actually,
Josh, as we know, tons of research is happening, and your states are considering IRRPO laws. And so, I think this is something that we'll continue to address as the research keeps coming out and we learn more as we implement more. So stay tuned.
I love this process because we keep going, right? We're not static, One of the things, this was raised by a good colleague of ours, and I'll open this up, but saying, it's great to do this, but what's the educational outreach look like for this? And I wanted to sort of bring in two people on this. One is Lauren, because the community need to be very important in this, as well as reaching out to, law enforcement, other implementers. So I'm going to start with Lauren. And then, Paul, maybe you could just talk a little bit about what the process looked like when we educated about the first IRRPO recommendation. And then I'm going three in a row here. And then Shannon, why don't you talk about our implementation efforts now?
Awesome. Thanks, Josh. So a big part of it is ensuring that, yes, a diverse set of community members are brought into the process, particularly during the development, but also very much important during the implementation stage. As Chris mentioned, that a big part of this is educating people to know what is the actual intent of the tool and recognizing that this is also a resource that is focused on getting people help and making communities feel safe and supported. And so a big part of this is, number one, making sure that people are aware of the tool, but also making sure that people are connecting with a diverse set of stakeholders, whether it's community groups, faith leaders, service providers, and law enforcement. And one of the things that I think a lot about at our work at the Ed Fund with our Virginia Advocacy Network, which is a self-sustaining network of advocates interested in reducing gun violence in disproportionately impacted communities in the Commonwealth, is really providing these spaces and looking for existing structures and doing some intentional external outreach outside of these existing structures to make sure that people, number one, are comfortable with the information, and then also making sure that these communities, if they do have questions, can circle back. Because I think a big part of what we've recognized as we started to have these conversations with our community partners is, once we were able really to provide the background on why IRRPOs were created and then explain that it is a civil tool, people were much more accessible to the idea. And so I think a big part of this is just making sure that community members are a part of the conversation, educating them, and then keeping the conversation going. And I think, Chris, to your point again, just making sure that it's an ongoing touch point. And I think that that is something that is very much an important part of this work is that it's civil, but also that there's an ongoing relationship, and that communities don't feel that once they start this process that they're alone and don't know how and don't feel supported throughout the process.
Thank you. Thanks. That's really important. And from the consortium part of it, to get the original IRRPO recommendations going in California and other places, we did an immense amount of education in the field and forums. Paul, you were part of some of those. I think we probably did about 15 different forums, 17 forums, I can't remember. But you want to talk about what that effort looks like, the sort of ability to bring experts in community and policymakers together?
Yeah, so let me answer your question, but let me also say something after that about education of clinicians. If IRRPOs include clinicians as practitioners, as the new recommendation suggests, there will need to be an enormous amount of outreach to the relevant clinical professions to let them know that this new tool exists, to ease their anxieties, which I described earlier about the ways in which it could be applied, and also to help them through this process so that they understand fully both how to do it and what the implications are and what their responsibilities may be once the process is initiated. And I would suggest that there are two key loci in that educational effort. One is the state professional organizations for the relevant professions, whether it's the state medical society, state nursing society, state psychological association, et cetera, according to the specific clinical categories that are covered in each state. The second key locus here are the facilities, hospitals and clinics. They have a strong interest in ensuring both that their practitioners know about recent legal changes and implement them properly. And so creating materials to work through the State Hospital Association, the network of community health centers and community mental health centers is another way of disseminating this information, which I think the question is right on point, needs to be done if this is going to be effective at all. So let me, Josh, answer your question directly, briefly now, which is with the previous IRRPO recommendations, one of the things that accounts for the successful adoption of this law in as many states and the District of Columbia in which it has been adopted is the outreach effort that was made, which I think will need to be made again with these new recommendations. And that included briefing sessions that were held in many different states, as Josh indicated, which brought together both local and national experts and local political figures, local voluntary organization members and leaders who would be key to advocating for IRRPOs, educated them about the recommendations, answered their questions, and in some cases led to testimony at legislative hearings when the bills were actually put up for consideration. So it was a pretty intensive effort to get the word out and answer questions, correct misunderstandings, and make sure that there was an adequate level of knowledge and momentum behind this effort.
So thank you, Paul. I sort of teased that out of you, but I did so because I want to let people know that we can't come to your community quite yet. We hope to be able to do that soon, but we can participate by Zoom. And so if there are people who are in the audience right now and would like us to brief, whether it's just a group or a coalition of groups or a physician, a healthcare provider association, we're here. That's what we're here to do. And part of today is to get this out and let you know that this is the plan. Our resource is to work with everybody to come to your community, whether it's in person or by Zoom, and we're happy to do that. We've done that also a lot with implementation of once the laws get passed. And so Paul was talking about educating to get a new policy. Shannon is really taking the lead in many ways in getting the laws implemented once they pass. Shannon, that's your expertise. So what do we know about implementation? What are your recommendations for people who say, hey, I have a law in my state, but it's not being used as much, or I'd like to see it used more, I'd like to add? What do we need to know?
So thanks, Josh. And I think this is, very much one of the areas of work in this space that we've all done that I'm most proud of, that we have not just sort of stopped at the legislative doors, that we've really followed through and work with communities, work with stakeholders to assure that the information is out there. We haven't done enough yet, but it's a priority for the organizations involved, which is great. So along the lines of implementation, Johns Hopkins and the Ed Fund and several other groups have partnered around a specific Implement IRRPO initiative. And what that has yielded is a specific website that's devoted to implementation. If you Google implement IRRPO and Johns Hopkins, you'll come to our website, and included there are videos from people on the front lines of implementation, resources that detail the different state laws, research and media coverage. So what we're doing on the implementation front is continuing those meetings that Josh and Paul talked about to educate community members, other stakeholders about this law. But on the implementation side, what do we need to be doing in order to have the systems and infrastructure in place in order to assure that these laws are being maximized and used to the benefit of the public? So part of that is education, part of it is resources, part of it is really identifying a champion at the state or local level who can really step up and say, this is important. This is something that we want in our communities. This is something that we need to be investing in so that we can have the types of clinical coordinators that Paul described, so that we can have officers like Chris who can do that follow-up work that are based on relationships with community members whose families are in crisis. They can have those, touch points that are so important to making sure that everybody understands what IRRPO is and are using them to the best possible outcome. I'll say that we also, this feels to me like IRRPO week in a way, because in addition to this wonderful consortium report and our webinar today, we also have a teach out that Josh is participating in, a key instructor in, that's live right now on IRRPO. So there's just a lot of activity happening right now around IRRPO implementation. So if you're in one of those states, if you're in a community that you say, gosh, this sounds like a great idea, I didn't know that my state has it, but it does. What can I do to make sure that it's used? Reach out to us and we can help.
Those are great resources. And speaking of IRRPO week, Paul Nestat from Johns Hopkins has a fantastic op-ed in the Washington Post today on this. And we'll definitely shout out to him for doing that, but also recommend that everybody take a look at that. So we have 6 minutes left, so we're going to get into lightning round activity here. One of our participants, a law enforcement professor at Johns Hopkins, asks us, has there been a study of the quality and extent of IRRPO training provided to police officers across the United States? I don't know that there is a study. Maybe someone can jump in on that, but maybe Chris, you want to jump in and say how important that might be.
Sure. So, we talked in the recommendations about having federal backing to support the implementation of IRRPO laws in the states that passed the laws. And it's right now in the state of Florida, it's on an agency by agency basis, whether or not there's any type of dynamic training regarding IRRPO. We're lucky that we, to put it in context, IRRPO in Florida passed on the heels of the Marjorie Stoneman Douglas shooting, which unfortunately in so many states seems to be the impetus to finally push IRRPO past the state legislature. So the focus here has been interpersonal violence more so than suicidal ideology. And we see that in the numbers, and we see that in the way it's been implemented. But there is, just from one agency to the next, there's great variation in the way that IRRPO is being implemented by different law enforcement agencies. And I do think that there is a need for something of a unified training regimen for the law enforcement in each state. And then I do like, again, going back to my comment earlier, I do like that IRRPO has the versatility to address gun violence on so many different levels. So I don't know that necessarily needs to be narrowed, or the way that you implement laws the IRRPO law needs to be narrowed. But I think better education, to Shannon's point, law enforcement is actually in the same boat as physicians. I don't feel that many agencies have the information they need to really utilize IRRPO for all it's worth. again, I'm lucky in my agency that they took the bull by the horns, but we're in the same county where Marjorie Stoneman Douglas took place. So I think it was right on everyone's mind when the law passed. So we saw in Broward County, we saw a lot more, of many more agencies just going ahead with it. But we see variation. I really do think that more unified training is necessary to get better results, to get better implementation across the board, and to potentially save more lives.
And just Jen, do you know of any I don't know of any studies that are looking at law enforcement implementation per se. Do you know any of the? I don't know.
Yeah, I don't. Gosh, it's a really important question though, and would be important to do.
So I don't read the names of the people who are asking the question, but sometimes I'll give a little identifier. So this is probably the last question, but it's to Paul, and it's from a friend of ours from Duke University, who's asking, do clinician-initiated IRRPOs threaten the therapeutic relationship? And why shouldn't clinicians rely on law enforcement for IRRPO petitioners?
So IRRPOs clearly involve a breach of the usual degree of confidentiality that exists between healthcare professionals and patients. And as a psychiatrist, I'm particularly sensitive to that. Confidentiality is an important principle, but it's a relative principle, which is to say there are many reasons that we would break confidentiality, sometimes in the patient's interest. And when a patient is suicidal and invoking an IRRPO might save their lives, that would be one of those instances. And sometimes when there's a threat to other people, we violate confidentiality to protect those people. That's something that we do already. The so-called duty to protect in one form or another exists in almost every state, and clinicians are used to thinking about acting on that duty. Why not rely on law enforcement instead? Well, if you want to talk about the extent of breach of confidentiality, involving law enforcement represents a more immediate and direct breach of confidentiality. Moreover, law enforcement then becomes a third party without firsthand knowledge of the situation that's evoking the concern in the clinician. So, on balance, it's simply better for clinicians to take the initiative here.
So this has been just a tremendous panel. I really want to thank everybody. We've gone an hour, kept most of our audience, so that's great. And I just, having so many thoughtful folks involved in this, I'm deeply appreciative. This report doesn't happen by itself. Vika was the main writer and shepherded this whole thing together so amazingly. But we couldn't do this without our partners, our consortium members, and our partners who give generously of their time to review drafts, to offer suggestions. And this is a very deliberative process. This process doesn't happen overnight. It takes time, but I think in the end, we get to places that are really, really, really important. And so I'm going to thank everybody for this. I'm going to respect the hour that we have together. And thank you for giving us your time today. And thank you to all the audience who hung in with us. And we are here to help. Please be in touch. We want to educate you, your community, and your stakeholders. Thanks for being here today.